convoluted and weird, just you tell me, I'm not
Like a lot of
afraid.
us here too.
Pardon me?
A lot of us are like that. That's just because we're dumb.
Anyways, so like I said, I'm pretty open about deviating from whatever direction I'm going so that I can answer all your questions. My intention here is for you to understand and make ventilation and the utilization of the ventilator and all their modes and all of that easier for you, okay? So in order to do that, I think that we need to start with the basics. And let me start with a story here. So I was on my first year at the university hospital. This was in 2010, and there we got called to a cardiac arrest. So cardiac arrest. To you, what's a cardiac arrest? What does a cardiac arrest look like in your world?
The person on the ground wedged between the bed and the wall.
Okay. All right. Who starts CPR on a cardiac arrest here?
All of us.
Most of the times you guys, right? And you guys have a process that you follow? Is there anybody that is at the head of the bed or in charge and then barking orders and everybody else is doing the work? Something like that, right? When I got to the hospital and the cardiac arrest got called in, I ran up to the room where it was, and we found this 450-pound woman on a bed, completely blue, nurse that was probably 100 pounds, if that, trying to do CPR, going like 1 and 2 and 3 and 4, you know? And then there was another nurse that was bagging this patient. The bag was a third of the size of this. So what kind of mask was she using? A pediatric mask, and it was right here on top of the nose, bagging, and it was like, the nurse was like 1 and 2 and 30, and the nurse is like 1, 2, and I got there and I was like, what the hell are we doing here? And she's like, oh, we're running a cardiac arrest. Awesome, let's do that. So then I told the nurse, hey, how about you let me take over the airway, and do you mind grabbing me a couple of airway adjuncts, like a nasal pharyngeal airway, an oropharyngeal airway, and take this shit and throw it away. And she's like, why? Aren't we supposed to bag a patient? And I said, yeah. So then we ran through the cardiac arrest. This lady didn't make it. And then after that, this nurse approached me and she said, so I thought that we're supposed to bag patients when we do a cardiac arrest. And I said, yeah. The difference is, can you please explain to me what bagging and how bagging works? And she explained it to me in a way that was completely different than what I understood bagging. The reason why I'm telling you this story is because I have had similar situations with paramedics that come to the university bringing patients, and sometimes people get offended when we as respiratory therapists don't listen to what the paramedics have to do. We just disconnect the vent and put them on their own, and we do our crap, and the paramedics are like, oh, this dumb respiratory therapist doesn't know shit, right? It's not because we don't know shit. It's not because we don't want to listen to what you have to say, but we have a different understanding of certain things that maybe you know, but we don't need your explanation to tell us how and why this machine is doing what you're doing, okay? So that's why I'm here. I want to help you guys be able to communicate with us in a way that we can understand the same principle that we know, but in a different perspective. Just like that nurse, she thought that bagging was with a little mask. Well, it's not necessarily with a little mask. There's bigger things and better things that we can do. Same thing here. You guys have an idea and a perspective of how this machine works, and I want you guys to understand that this machine is awesome. There's more that this machine can do, and I want to kind of put them both together, okay? In order to do that, we need to learn some basic principles that I want you to understand. Where's the eraser here? So first of all, can anybody tell me that what does the ventilator and all the things that the ventilator has, what works for oxygenation? Any of you know? I just need, spew it out. What helps with oxygenation? Tidal volume, PEEP,
PEEP.
all of those. You tell me.
PEEP and FiO2.
Okay? PEEP, FiO2. Anything else? Anything else? Yes. I to E ratio. Okay? That helps with oxygenation. What helps with ventilation?
Volume and rate.
Tidal volume?
Okay, tidal volume. What else?
Rate.
Rate. And this one and this one are related to each other. If you put them together, you get something. What do you get? Minute volume, okay? Anything else that's related to ventilation? Okay, the only reason why I'm telling you this, because in order for you to understand what I'm gonna explain to you, you have to understand that there's a difference between oxygenation and between ventilation, okay? All right, this is on a ventilator. This is specifically talking about invasive ventilation. However, in non-invasive ventilation, what's non-invasive? BiPAP, CPAP? There's the same principle. Something that's related to oxygenation, something that's related to ventilation. Okay, in that regard, let's say CPAP. Is CPAP related to oxygenation or ventilation?
Oxygen.
So it's confusing. Technically, for CPAP, CPAP by itself is oxygenation, right? But when you place somebody on CPAP, the only reason why CPAP helps also with ventilation, it's because when you have alveoli in the lungs that are collapsed, and then you create CPAP or pressure to open them up, then you no longer have a collapse of airway, therefore you no longer have a loss of surface area for ventilation, therefore you can ventilate better because there's more air that is going to go in. Does that make sense? So in all reality, CPAP is for oxygenation only, but a result of CPAP is ventilation because of surface area. Okay? Now, the other option is BiPAP, right? Technically it's not, I'm calling it BiPAP, but it's a trademark, whatever, I don't give a shit about that. BiPAP. There's two pressures, okay? So there's one for oxygenation and one for ventilation. Which one is which?
I would say the.
And give it a guess. If you are wrong, that's okay. Just give it a guess.
Expiratory pressure would be for ventilation, the residual pressure of the PEEP would be for oxygen.
Perfect. So IPAP,
I'm still a paramedic.
IPAP or inspiratory pressure
Dust off that information, but it's down there.
is for ventilation, and EPAP or expiratory pressure is for ventilation, right? And that includes the FiO2. Okay. Are we good there? Do you have a good understanding of that? All right. I need a volunteer here. Just somebody to come stand up here. Just come on. So I want you guys to understand the principle of PEEP. Okay? First of all, how strong do you think this man is?
So strong.
Pretty strong, right? Look at
Yeah.
him. All right. So PEEP. So PEEP, can somebody give me the definition of what PEEP is? What does PEEP stand for?
Positive and expiratory pressure.
Positive and expiratory pressure. Anything that after we exhale, there's a pressure that maintains the airway open, okay? So we all have an intrinsic PEEP between 4 and 6. Let's say 5, just for the purposes of staying normal, right? So 5, imagine that I am PEEP, and this is oxygen, okay? When somebody breathes normal, PEEP is doing this. Just pushing him, and what is he pushing him for? What actually PEEP does is, imagine that there's a wall right here, and what I'm doing is pushing oxygen to go against the wall so that sorry, I'm abusing you here, but so that the oxygen can cross that membrane, that wall of the lungs, okay? So what can cause something that does not allow oxygen to be pushed easily like that? What's the cause of that? There's many reasons, but give me now. Fluid, perfect. What else?
Obstructions of any
An
kind?
obstruction, correct. A collapse, perfect. Any disease that creates a thickness larger than what normally is in the lungs, like fibrosis, pulmonary fibrosis, lung contusions, things like that. So the way, if you imagine PEEP, every time that you increase PEEP on a ventilator or on the non-invasive machine, BiPAP, whatever it is, what you're doing is, this is 5, this is 6, this is 10. You see what I'm saying? Thank you. What you're doing is forcing the oxygen to go across that membrane that now is thicker because something physical is there that is not allowing you to have the oxygen go across the wall. Okay? Are we good with those principles? Are we good? We understood? All right. By the way, I totally forgot to ask, what people do we have here? Paramedics and what else?
All the above.
Advanced
A
and
big,
basic.
huge range. Okay. Any basics here?
Mhm.
Yes? Oh, man. Basic, advanced. Okay, so I'm an advanced EMT. I'm a respiratory therapist. I'm a firefighter. I try to do everything. So I feel your pain. If it's a little over your head, just tell me. We can spend a little bit more time explaining some more of those things. Okay? If that's what you want to do. Otherwise, you don't ask me questions, I'm just gonna keep going. So please ask questions, okay? All right, so are we good with that? Perfect. Now, there's a relationship that I want you guys to remember before we go into the depths of all of this stuff. So, minute ventilation. How do you get minute ventilation?
Tidal volume times the rate.
Are you sure it's times?
Right.
Yeah.
So tidal volumes divided by respiratory rate equals minute volume, right? Okay, so I want you guys to remember this formula. This formula is important for everything you do. Everything you do, okay? All right, so now that we understand the basics and we have all of the what are they called? Different things that different things do on the ventilator. Oxygenation, ventilation. So let's talk about settings. What kind of modes does your ventilator have?
SIMD, did you talk about like that
Yeah.
kind of stuff?
All right, so we're gonna talk about basics here again.
So it has assist control,
So it has assist control, SIMV. Does it have a
it
CPAP?
has CPAP and BiPAP,
And by level.
by level, sorry.
Whatever.
Right?
All right. And it's assist control and it has pressure
And volume.
and volume, right? All right. I don't like that color, nobody can see that. All right, so on assist control, what is assist control? Assist control is a mode that you put on people that normally cannot breathe on their own, so they're not breathing at all, or if they're breathing, they're not breathing appropriately, okay? Assist control means when the patient is not breathing at all, it's completely apneic, the ventilator is gonna assist them, meaning it's gonna give them a breath, it's gonna give them a volume of air, it's gonna give them the PEEP that you gave them, that you are assigning, and it's gonna give them an FiO2. And control means that just because you have them on this assist, if the patient triggers a breath, the ventilator is gonna allow them to get that breath, but it's gonna be given exactly at what you said, okay? Now, on pressure control, what do you set up? A pressure or a volume?
Pressure.
Pressure. So think about it this way. On pressure control, pressure is a limit, volume is not constant. It's changing. So pressure control is the limit, and then the tidal volume, it's changing all the time. On volume control, what do you set?
Volume.
Volume. So volume is the limit, and pressure is the changing number all the time. Okay? Why do I explain to you that? It's important for you guys to understand when you set up a ventilator, what you set the ventilator on, you need to understand what's going to change and what's not going to change. Okay? So after that, all of them have a respiratory rate, all of them have an FiO2, and all of them have a P. Right? Have fun, you guys.
Thanks.
All right. What's SIMV? SIMV is similar to assist control. The difference is that assist control assists them when they're not breathing and when they trigger the breath because they're doing a little effort to breathe. It gives them a volume or a pressure specifically to what you said. SIMV doesn't, right? SIMV gives them a pressure or a volume that is assisted, but controlled. But when they breathe on their own, then you have to set something that's called pressure support. So that means that they're just gonna get a little hump of air on every breath that they take spontaneously, above the set rate that you set on that ventilator. Are we clear with that? All right. Then CPAP. CPAP and bi-level, whatever you guys call it. That one you just said an IPAP and an EPAP for bi-level, and then you said an EPAP for CPAP, correct? So let's start with, are we clear with that? I want to start first with BiPAP. The difference between BiPAP and CPAP. Why do we put patients on BiPAP? Why do we put patients on CPAP? Anybody wants to take a wild guess here? Why do we put someone on CPAP? What's the purpose of CPAP?
Help open up the airway and prevent atelectasis.
Good. So try to open up the airway and prevent atelectasis. So if you have a patient that is, let's say, I'm going to give you a scenario here. So you have a patient that is breathing 4 times a minute. Their saturations are 60% when you arrive there. They're spontaneously breathing because they're 4 to 6 times a minute breathing, right? And you notice that when you listen to their lungs, you listen to lung sounds up on the upper lobes, but in the middle and lower lobes you hear nothing. If you didn't have the ability to intubate this patient, would you put him on CPAP or BiPAP?
CPAP.
If you put him on CPAP, what is CPAP going to do? It's going to open up the airway that is not open in middle lobes and lower lobes. But is it going to help with the respiratory rate? Okay, so you tell me, a 4 to 6 respiratory rate on a normal adult, is that normal?
No.
Okay, so this is what I want you to remember. Anytime that you see a patient that cannot and does not have a normal respiratory rate, please don't put them on CPAP. Okay? CPAP does nothing for them. BiPAP helps ventilate the patient. So in a way, what I want you to know is CPAP, it's specific to oxygenation problems. How do you spell that? Right there. And BiPAP is more so to ventilation problems. Okay? And like always in medicine, there's a caveat to it. So, just because I'm telling you that you have to put somebody on CPAP for oxygenation and BiPAP for ventilation doesn't mean that you cannot do the opposite, because you can. There's caveats to it. But as a rule of thumb, and speaking in general terms for patients that you have, Anybody that is having oxygenation problems, put them on CPAP. Anybody that is having ventilation problems, put them on BiPAP. Okay? So why is that? CPAP has something that BiPAP doesn't have. Anybody knows that? Remembers that? This. Respiratory rate. Unless your ventilator specifically has a bi-level mode that doesn't have a backup respiratory rate, the majority of ventilators that have a BiPAP mode, they always have a rate for that specific reason. BiPAP is specifically made, it was a mode that was specifically made to help patients ventilate better. But because it's uncomfortable to put a patient with a high level of CPAP, let's say 15, and maintain him on that and keep breathing in and out at 15, they put a pressure that is lower that helps them give a break when they exhale, but still helps them stent the lungs. So think of it as when you're inflating a balloon, and you inflate that balloon and maintain that balloon open, when you pinch it, that's what CPAP is doing, right? It's pinching that and maintaining that pressure in the airways, stenting the airways. So CPAP stents the airways, BiPAP stents the airways and allows them to breathe so that they can move the gas around so that they can breathe CO2. Okay? Any questions about that? No. All right. So now, what are normal settings that you put people in? This is something that is super difficult to do because everybody wants me to give them a specific number that you can put somebody on. Where do you start? Well, I start by looking at the patient, okay? So I want you to remember something important. What level of PEEP did I tell you that is the intrinsic PEEP that everybody has?
4 to 6.
4 to 6. So there's no reason why you should put anyone any lower than that. And there's no reason that if your patient is struggling, you should put them at the normal. Because their normal is not working, right? So if you find someone that is having problems, why would you start at 5? Don't start at 5, because 5 is not working. So I normally, when I put patients on CPAP, I start on 7, 8. That's where I start, okay? Now,
I do have a question.
yes,
What is, I guess, how high, I'm only advanced, so I don't understand a whole ton.
oh, you're okay.
But,
You understand enough.
at what point do you get at where you can actually be causing, like, more damage to their lungs in PEEP? Does that make sense?
Yeah,
Like how high of a setting was that?
Like barrel trauma, like too much pressure.
Yeah, too much pressure in their lungs is gonna cause, and let's say this is just like in a normal adult-sized person, patient, so like somebody between 190, 200 pounds or so.
okay. So when you have a patient that requires high levels of CPAP or PEEP, in order for you to start increasing the PEEP to a point where you think is appropriate, you should start increasing PEEP at normally 2 to 3, right? So if you put them on 8, and then the patient's still not responding to that, you increase it to 10. Not responding to that, increase it to 12. And at what point you stop, or at what point you're damaging their lungs. Okay, so are we really worried about damaging their lungs or helping them breathe to get them to the hospital?
I gotta breathe first.
Help them breathe to get to the hospital, right? So yes, you have to worry about when you're gonna damage their lungs, and you're gonna notice that, to answer your question, you're gonna notice when you are creating problems by the pressure that you put them, by your vitals, okay? So what is PEEP? I explained to you that it's a pressure that is created into the lungs. What's in between the lungs? Our heart. So when you give pressure to the lungs, the more pressure, I can't explain to you that on the board, but the more you put pressure on the lungs, what do you think the lungs are doing to the heart?
Just squeeze the pressure.
What happens when the heart cannot expand?
Can't backfill.
Can backfill, right? So if it cannot backfill, what do you think is gonna happen to your vital signs?
Pressure's gonna drop.
Right, so if you think about this, you start to give PEEP to patients because they cannot ventilate or oxygenate per se, more so oxygenate, right? And you're starting to put pressure into the heart. What's the first response of the heart against stress, pressure? The heart rate goes up, right? And if the heart rate goes up, what happens to your blood pressure? It maintains normal for a little bit, but then once it's too high, what's gonna happen to it? It's gonna dump because the heart cannot compensate for that, cannot pump blood fast enough because it's pumping too hard. So it's not a perfusing rate, right? So that's a sign that you can see when you're creating problems to patients. You gave too much PEEP, your vital signs are normal, and then all of a sudden you increase your PEEP by 2 more, and then now your heart rate is really high, and then your blood pressure starts to go down. You need to think of, oh, what did I do to cause that because it wasn't this way? Back up the PEEP too, and your heart rate should come back to where it was before, and your blood pressure as well. In regards to damage to the lungs, you cannot necessarily see physically how much damage you're putting to the lungs when you're giving them pressure, but what you need to know is that it has to do more so with when lungs are damaged already versus lungs that are not damaged already, okay? If lungs are healthy, doesn't matter how much PEEP you put in them, as long as you're doing it appropriately, it's not going to damage the lungs for the amount of time that you have them under your care. For the amount of time that I have them under my care in the hospital for a month and a half, yes, it's going to do damage. But your transports are, how's the longest transport here? An hour, maybe?
Yeah.
At best. In an hour, unless you give them a lot of PEEP to the point that you're gonna create a pneumothorax, that's the only damage you can do. And unfortunately, that's something that you can't foresee in certain circumstances. In circumstances where you have a patient that has damaged lungs already, like pulmonary fibrosis, and you're starting to see pressures that are really high and you keep going up and up and up and up and up, then you are doing damage to them because there's something that's telling you you can't do that, right? So just realize, according to the disease process that this patient has, if it's pulmonary disease process, you have to be more careful about the amount of PEEP that you give them. If they don't have a disease process, but it's a trauma patient that is having problems breathing, is it a disease process that caused the problem? No, it's the trauma, right? So let me give you an example of somebody that you should put on CPAP that is a trauma patient. So driving on the freeway, a person that has a seatbelt on crashes at 75 miles an hour, rear-ends somebody, and then you are right there, they're breathing really fast, you listen to breath sounds and they're gurgling all over. Why do you think that's happened there?
Trauma to the lungs?
Yeah, trauma to the lungs. It's possible that they had a pulmonary contusion. What's a pulmonary contusion? Right. So technically it's a bruise in the lung. It's possible that sometimes that bruise starts to bleed a little bit. Is that blood creating a problem for oxygen to go across the membrane of the lung to go into the tissue? Yeah, because it's not supposed to be there. So in order for you to help that patient, put him on CPAP. Can you do anything for the pulmonary contusion? No. There's nothing we can do about a pulmonary contusion. Here or in the hospital, there will be nothing we can do. It's gonna heal on its own. But what you need to do is let them oxygenate in a manner that is gonna help them not have an anoxic brain injury. Provide CPAP for them that should help them move and stent those airways so that the blood stays out, right? So one of the things that you know, the majority of you should know about physiology of the lungs. So the lungs are a high pressure system or a low pressure system? Low pressure system, right? What's a higher pressure system than the lungs? Circulatory system, right? What happens when your kidneys are not working really good and water starts backing up? Where is it gonna go? It goes to 2 places, right? It works against gravity, so down is correct, it's facing your legs, and also it's trying to find a place where there's no pressure that is gonna not let them in. That no pressure place is your lungs. Congestive heart failure patients that have pleural effusions, Those kind of patients, that's liquid that is looking for a place to go. And that liquid always, always, always goes into the lungs. When you have a patient on that with those kind of diagnoses, what method of ventilation do you put them on? CPAP or BiPAP? So what's the problem?
The fluid in the lungs.
Fluid in the lungs. These patients complain of, I can't breathe, trying to take a breath, I can't breathe. So the fluid in the lungs is in the lungs because the pressure is what?
It's low.
Lower than what is in the circulatory system. So what do you need to do to get that fluid out? Increase the pressure of the lungs to move that fluid out in order for that to move out of the way, right? CPAP works really good for that. However, if those patients are working really, really hard, sometimes, this is one of the caveats that I was telling you, sometimes those patients, when they have difficulty breathing because there's fluid in their lungs and they start breathing so fast, what happens when a patient is breathing so fast for a long extended period of time, eventually they're gonna tire out, right? And if you don't do something before they tire out, you're gonna send them into respiratory arrest because you didn't do something. CPAP works when it's the beginning of a congestive heart failure exacerbation. BiPAP works better when it's in the middle or almost to the end. Once it's at the end, there's nothing you can do, but you have to intubate that patient, right? So how do you make the difference between the beginnings, the middle, or the end?
Probably the work of breathing that you see with your patient.
Perfect. Their work of breathing. On a patient that has fluid in their lungs, the beginning of difficulty breathing because of a CHF exacerbation or fluid, it's like, I can't breathe, but they still have a normal, somewhat normal respiratory rate. Maybe a little bit high on the 20s, 18 to 24. When the patients are having an exacerbation because of fluid, and they already have a rate that is like on the 30s or 35, CPAP is not the answer. BiPAP is the answer. And the reason for that is because BiPAP is gonna provide a backup rate, meaning every single breath that they're gonna take at the rate that you set is gonna give them the whole amount of pressure. Okay, one of the things that a lot of people have problems here, specifically EMS, is BiPAP and CPAP. These dumb masks are a pain in the butt, aren't they? It's like, so how do you explain someone that you are having difficulty breathing, yet I'm gonna put a pillow over your face and it's gonna help you breathe? How? So, and especially these patients that have never had a CPAP mask on their face, how do you do that?
Out of bed.
Great answer. It is. A lot of people are afraid of answering that, but that's the answer. The only reason for why patients do not understand and do not tolerate a CPAP mask or a BiPAP mask is anxiety. If you don't fix their anxiety before you put them on that mask, I don't care how much changes you make onto that machine, it's not going to help. So give them something that is gonna tone down their anxiety a little bit, but obviously don't take their respiratory drive away, okay? And then once you fix that, put the mask on and then give them what they need, okay? So, for BiPAP, settings. What settings do we start them on? So there's something that I need to know that I tried to figure out about your ventilator, but I could not figure it out. So you guys are gonna help me out here. When you set up someone on BiPAP, let's say I want them on 10/5. What numbers do you put on your machine? Do you put 10/5 or do you put 5/5?
We put 10/5.
You put 10/5.
10 over 5.
Everybody is on the same page there? Yes? Yes?
Nobody
Okay.
knows how to do it, yes.
Okay. All right, so that means your ventilator is at not PEEP compensate. It doesn't compensate for PEEP.
Right.
What that means is that if you put them on 10/5, it's going to be 10/5, right? The complete pressure, the delta pressure is 15, but the pressure doesn't compensate for the PEEP that you're giving him on the bottom, right? There's other ventilators that don't do that. So I just need to know the difference in order for you to know what to do when changes happen on the ventilator. Okay, so putting patients on a pressure of BiPAP has to do with their body habits. Okay, so a normal body habitus patient. And how do we define normal? My definition as a respiratory therapist of normal is anyone skinny to the point of like maybe large but not morbidly obese, right? Does that make sense? So please don't get offended. I'm not gonna judge anyone here. I'm just telling you. I would put her to start 10 over 5. I would put him 12 over 5. I would put him 10 over 5. 10 over 5. 12 over 5. 10 over 5. 10 over 5. 10 over 5. 8 over 5. 10 over 5. Does that make sense? Can you see what I'm doing?
Yeah.
So, sorry. 8 over 5. It has to do with how you're built. If you have an individual, male or female, that is laying on the ground, having difficulty breathing, this patient is 450 pounds, and you start him on 10 over 5, what the hell are you doing? You can't do that. The only reason for that is, think of all the pressure that fat is posing onto the chest, right? Regardless of them being laying down or sitting up, the heart still has to pump blood to all of that. The body still and all the accessory muscles have to work that hard to move all of that pressure that fat is putting into that patient. So put them on a higher pressure. Basic normal body habitus patients start 10 over 5, 10 over 8, 12 over 8. You see, did I deviate from any of that here? No, because all of you look like normal body habitus. Anybody that is larger than that, don't be afraid of starting on 15. 15 over 8, 15 over 10. Okay? Does that make sense?
Mhm.
Now, let me explain to you some things about this BiPAP. We said that BiPAP has two pressures, right? I'm giving you two numbers. The number on the bottom has to do with what? We said?
Pete,
Oxygenation. If your patient is not oxygenating well and you have them on 10 over 5, what do you need to do? If you already have them on an FiO2 of 100% and they're starting still 88.
Increase your
increase your peak.
You increase your PEEP. However, there's something that a lot of people don't understand. That's why I'm explaining it to you. 10 over 5, there's something called pressure support, or the amount of air that you're utilizing to ventilate the lungs. What is the pressure support on this number, the 10 over 5? 5. Why? Is the difference of 10 minus the 5, right? So, if you have a patient that is having a hard time breathing because they are fluid overloaded per se, and your SATs are 88, you have them on 100%, and you go from 10 over 5, you go to 10 over 8. What have you done to your pressure support now? You've reduced it. So now you're going to notice that their tidal volume was 500, and now it went down to 300. Have you fixed the problem? You have,
maybe.
but you've created another problem. Does that make sense? What you have done is fix the problem of oxygenation, but now you've given them a problem of ventilation. And do you think they're going to tell you, I can't breathe, I can't breathe, I can't breathe? Yes, they're going to tell you that because you did not change this number on the top. So, and this is why we have to know if your ventilator is PEEP compensating or not. If what you guys say it's true, that it is PEEP compensating, that you put them on 10 over 5 and it's 10 over 5, if you increase this PEEP to 8 for reason of this tidal volume that is going to drop, you have to inherently then increase your IPAP the same amount that you increase your EPAP. Does that make sense? Are we clear on that? So if your patient is 8 over 5 or 10 over 5 and you increase it 10 over 8, so in order for them to get the same amount of tidal volume, now you're going to go to 12 over 8. Okay? It's not the same when you increase the IPAP. So why? If a patient is let's say you have a patient that is, that you go to the hospital, they tell you that, we have this patient on BiPAP because his CO2 is 65, I want him to ventilate, so I put him on BiPAP. Put him on a rate of 20, he's on 12/5. So 12/5, what's the pressure support of 12/5?
7.
7. That's giving me a tidal volume of 450 for that patient. So I put him on that machine, on BiPAP, 20 minutes ago and their CO2 was 65. You ask for a blood gas, they give you a blood gas and their CO2 is 62. Has that thing done anything?
No,
Yeah,
not really.
but not enough. Come to find out that this patient is 6'5". Is that tidal volume appropriate for that?
No.
Not really. So what do you need to do? Have him breathe more. Blow off more CO2, right? Tell me how you do that with BiPAP. You have him on 12/5. What did we say on BiPAP? Fixes ventilation and what fixes oxygenation?
Increase their IPAP.
IPAP fixes ventilation, right? So if you do that, what you're gonna do is you're gonna increase it to 14/5. So now what's the pressure support? 9. And then that should increase your tidal volume to probably 520 or so. I'm please don't think that those numbers are exact. I'm just throwing out numbers here. Every single change that you make is dependent on the body habitus and the lungs and all of that of the patient. So one rule of thumb that I do when I move patients, I always move the numbers by 2, every time, by 2. Unless the number is outrageously, egregiously wrong, then I move it by 4, right? So let's say that your patient is the same patient, but your tidal volume is 250 on that. Are you gonna make a change of 2? To increase that tidal volume so that they can breathe out the CO2? No. You should increase that by a good 4, okay? So that that number goes up higher and so that they can ventilate harder. But can you see that when you are moving numbers for ventilation, the IPAP has nothing to do with the EPAP, right? So you don't move anything on the bottom. But when you do the opposite, when you're doing oxygenation, you move the bottom, you have to move the top together, okay? So another problem that that helps with the issue of I can't breathe, it's uncomfortable, is this little thing right here. What is this? On I-to-E ratio, what is this called? Inspiratory time, right? So why is inspiratory time important? So
That helps with patient comfort.
exactly. So inspiratory time has to do with how fast the machine is gonna deliver that tidal volume that you've set on the BiPAP, okay? So if you have a patient that is complaining that they can't breathe, what do you need to do to get the air to them faster?
You want it faster,
You want
increase
to
the
decrease
ratio.
that number if you want to deliver a faster breath.
Right. So you gotta deliver the breath faster, right? You gotta shorten the I time so that it gives the number faster. The problem with that is that when you do that, it doesn't allow them to, it allows them to exhale for a longer period of time, but sometimes it doesn't provide the full tidal volume that you said because there's not enough time. So you have to be mindful of when you use that I time. It's directly related to a number that you set, that one. Okay? If your respiratory rate is too high, but your I time is too high too, it's never going to get the tidal volume that you told it to give. So be mindful that when you are helping patients be comfortable with BiPAP, try to keep your respiratory rate on the lower end of fast. What I mean is 24 and below. If you get a rate of 24 and below, you can give them an I time that is higher. The I time that is higher is gonna give them a bigger tidal volume and it's gonna make them not feel so short of breath. Am I confusing people or am I being clear here?
That makes sense.
Make sense? Okay. please interrupt me if you have any questions, if there's something that you don't understand. Please interrupt me so that I can explain it to you. So far, are we good? Okay, perfect. Any questions about BiPAP, CPAP here? So, I have a suggestion for you, a recommendation when you guys are doing BiPAP and CPAP. It is very hard to put patients on BiPAP and CPAP when the machine is running and the mask is already plugged into the machine. I understand that your patients are gonna feel really weird, and the majority of the patients that you see are these people that are tripoding, diaphoretic, sweaty, they can't breathe, all of that. But if you just take a little bit of time to set that mask appropriately, it's going to make a big, huge difference. The best way that we as respiratory therapists are taught to place a mask appropriately is without the device connected to it. So put the mask on them, attach it quickly, make sure that it's completely set appropriately, and then put the machine on. If you do it the other way, the machine is blowing air, and when you put that mask on, the lining of your mask, I don't know what mask you use, but the lining of your mask that is like that plastic stuff kind of flaps around, and it creates like half seals in some areas that is not allowing the air to technically be pressurized in there, okay? If you have patients on beards, that's the hardest thing you can do. If the patient doesn't allow you to cut the beard or shave it off, cinch it. The 30-minute travel that you're gonna do is not gonna do any necrosis on their face. I promise you that. Just cinch it up, okay? And then, what's the other one? Oh, people that have no teeth and people that are really large. Do you guys have how do your masks come? Like the packaging of your mask? Is it just like a,
Is that one of the
That's that.
inspection?
oh,
That one,
this
that's.
is what you use?
Yeah.
So
I'm so disappointed. Okay, it's okay. What I want you to do is make sure, is it a one fits all?
No,
No.
we have that.
You have sizes,
Yes.
okay. What I was trying to tell you is, some of the masks that you have a measuring device. I just wanted to show you, but if you don't have a measuring device, the best fitting for anybody, the top of the mask goes up right here, and the bottom of the mask goes between the fold of your lip and the bottom of your chin. That's where it goes, okay? So in between those two. If your patient has no teeth, that's really difficult to do because right here it goes into their mouth, get a bigger one. If it goes below their chin, that's totally fine, just cinch it, okay? One of the things that I have noticed with people that have EMS services that come to the hospital with BiPAP or CPAP is that the mask is not cinched up. It's not tight enough. And all the air is coming out and they wonder why the machine is not doing as much as it should be doing. Okay? So, any questions about that? No? So, please give them medication to reduce their anxiety. What medications do you use out here for that? Ativan, Versed. Okay, perfect. Please use those. Use them appropriately. Don't suppress their respiratory drive, or don't give them enough to suppress their respiratory drive. That's not what you're trying to do. You're just trying to calm them and relax them. And then put the mask on. Put the machine on to whatever setting that you decided to put them on. If it's not working, increase them. Paramedics are fantastic at giving peace of mind to people. I was going to tell you a story about him, but never mind.
Go ahead.
No, let's hear it, let's hear it.
I got a couple I'm gonna share about you too.
That's why we have during each other, so, no. No, but I understand that a lot of people don't feel comfortable, but that's something that you have to do to make people comfortable. I'm not asking you to hold their hands, but I'm asking you to give them a little bit of peace of mind. Hey, I understand that this is not feeling comfortable. I promise you it's helping you move air in your lungs. Try the best you can to slow your breathing and relax, and I'll try to help you on my side, okay? Let them know, hey, I'm giving you something to help you relax a little bit. That sometimes a lot of the problems that you have and we have with patients on BiPAP is right here. their brains are like, I can't breathe, and the brains goes to shit. And you just need to have them think with their frontal lobe and say, dude, relax, I'm helping you here, come on, I'm gonna give you medication, I'm gonna put this mask on you, it's gonna feel weird, just explain the process to them. One of the worst things that you can do is have a patient that is short of breath, and all of a sudden just say, hey, I'm gonna help you, smash! Put everything on without explaining it to them. That patient's gonna go batshit crazy on you. So please don't do that, okay? Any questions about that? Can we move on from BiPAP and CPAP? Are we good with that? Anything that you guys want to know, ask me about that? Don't be afraid of using high pressures, please don't. I have used BiPAP at 28/20. If the patient is big and if the patient needs it, I'm gonna do it.
Is everybody familiar with how to set up CPAP, BiPAP on RMed? Like completely, we got a lot of gaps.
No?
You think
Okay,
we could take a second to
Yeah.
just go through the,
Yes.
you know, the buttons and how to set it up and?
Does our student rate
That's what
No,
I recall that being.
you can do a limit of like a higher limit and a lower limit, so they can't pass it or won't give it. but
You wanna
we
jump
won't.
up and help him with, setting some stuff up?
Yeah, that's what we were talking about. I'm like,
It just didn't yesterday, and I was like,
Yeah,
ah.
I'm not gonna really go with that. The dog just put on there.
You know what I'm doing, kind of competent with it.
there, so there's CPAP right there, right?
Does everybody else have or did everybody bring in their vent bag? So grab your ventilator out and just kind of walk through the steps. If you guys are unfamiliar with it, get your face in front of a ventilator so you can be
So
comfortable.
whoever is not comfortable, come on over here and I can show you.
You come right here.
You know how to set it up.
Yeah. Yes, we did, I was with, Luke, we did a ride. Yep.
That's why I was.
Yeah.
Okay, so let's start from the beginning. So you turn the ventilator on, this ventilator takes forever. I have no.
It tells you.
So you guys can look right here. So where it says max CPAP, check, and then that's the no CPAP right there. So what you're going to do is, if you want to change from CPAP to BiPAP, just select that, and that's gonna allow you to change CPAP or bi-level, right? Right there. You see that's bi-level? Bi-level right there. Perfect.
After guys.
So,
Well, I didn't want to be rude and be on my phone texting them, but presentation.
yeah, so every single ventilator is fluorescent. They post to pose, white to green, white to white, all of them are fluorescent, regardless of whatever you do. All of them are, okay? So, right there, so you are at feedback, and then the pressure that you are on.
For some reason, I was thinking it was 9, but that.
So for CPAP, you change the CPAP to this number, CPAP by, and
Is yours not
right?
automatic like that?
And then apparently this ventilator has, you can do bi-level without respiratory rate or bi-level with rate, so CPAP would be without a rate, I would assume that's what it's doing.
Yeah, so both CPAP and BiPAP, we can't choose the breaths per minute, so we can't choose the rate, but we can set limits as to like, it won't let it go below and it won't let the
Yeah.
machine do above, but we can't control their rate.
Right. So CPAP or BiPAP, you cannot control the rate on this thing.
No,
That's normal.
they control it.
Okay, so.
So anything in our gray, like that's outlined, we can't control in
Yeah.
that mode, and
Yeah.
then, so yeah, we
Okay.
can't ever control.
Yeah, so what I want you to do, what I told you is, if you're setting somebody, if you have somebody set up a bypass and you need them to have a respiratory rate, what you need to do is compensate for that respiratory rate, is just move your pressure higher, so that they can get better air. And that should either, if they're having difficulty breathing because of a COPD exacerbation or CHF exacerbation, the high pressures will help them support their breathing that they're doing on their own, and they'll drop their respiratory rate. And they will. Okay? If they're not breathing on their own, just, I wouldn't put anybody that is on CPAP or BiPAP that's not breathing at a spontaneous rate less than 12 minutes. And I don't know if you guys have protocol for that, I guess. So, don't.
They just have to have their own respiratory drive and be not.
It's perfect, yeah, it doesn't, another contraindication for BiPAP or CPAP is emesis, right? Please don't put anybody that is actively vomiting without you fixing it, because if you're not there watching, all you're doing is shoving that vomit is back into their throat, and it's gonna go into their lungs, and it's gonna mean that they, have a pneumonia, and then I'm gonna say, that's another. I promise, I'm not afraid to tell you. Anyways, so are we understanding here? So choose your mode, CPAP or BiPAP, then you choose your pressure. So right here, this is how we set it up. 5, 6, 7.
The green check change it.
Is she gonna do it since the last one was on?
Can you guys see that? That's what I was talking about, the lungs, when you put certain part, it just
Why would I do that?
inflates and inflates and inflates and inflates. The more you put on it. So right here,
The ones last year.
so,
Well, she was also
you
pregnant.
see that?
Don't you think her
How it
situation might
increases and
change?
She just doesn't.
So that pressure that is there is actually pushing them apart. So the more pressure you put in there, the less the heart is able to
I
move.
also just wrote it because it was easier to
Please
get out.
think of that when you set them up. And so this by the way is the same thing. With these numbers, right?
Yeah, so then we are,
So like that one you got right there.
but no respiratory.
So, and this is what I was telling you about. So
He's not talking to me.
ventilation,
Nick.
then
Go ahead
the
with your
number on the top.
Just
stand over here for your sake.
It
is super uncomfortable. If you ever get a chance, we have some drinks. If you get a chance to put it on yourself, it's like, it's equivalent to your I'm trying to breathe because it forces air in, it's super uncomfortable. But we're in a normal state right now, right? You don't need that, so you're not air starved or and people that can't breathe, their lungs are higher, they're have more time, right? After a couple of breaths. For you or I,
The ways I've had success with it is just by not necessarily slapping Ray's approach to it in the hospital is different because they have different style masks. They have so much just right. I've had it where we tend to allow them to wear the mask at the same settings that you're on now. Get it filled with the timing, different machines, so just a little paragraph. And then once you bridge that, then she's
that's what settings.
when you just slap it on, in most cases, for me.
Does anybody know how to access that right hand?
Hey, this is what's going on, it's gonna feel a little bit different for you.
Respiratory site.
No, this right hand up here. So I'm looking for the eye time and I'm looking for the right hand.
Good start.
Just as that full pressure.
Yeah, so that'd be pressure support.
And a lot of this for us, that's right.
That was good.
horses raised.
That's 42, it's because we
No
don't.
more stuff out the back, getting stuff out, getting it set up. For the most part,
Most of the time,
they should.
most of the time when I'm
But
influencing.
for some reason, Grace, that situation, get up that stuff, get it stuff, see pounds, wipe out,
Where
get
they're
it
not,
deep side of this.
where they're getting
You
rusted.
should be able to-
And then I would try to influence that.
No one's gonna expect us to be experts on it. She's an expert. We use it.
As far as the rise time and everything, influencing your
Yes, I know you
ID
did.
that way.
There we go.
So.
So your IQ rate
Then you have to press the button, slide it up.
and then you can actually.
So, when they take a normal breath, it doesn't give
I'm just glad I have a green patch. I get to escape
I'll pass that on, I'll pass that on.
So does that, even though it's in here, does that count? Because like it's still showing is that's the patient's pressure.
They're not breathing, these are so
Even though we
strict.
just
And
here.
another case, remember, it's super important to use some of those parts. If you're going through and you're trying to start to tomorrow, we're doing something, you don't know what you did, you change it, you don't have to bypass. Or no,
Yeah, no.
you get in there and there's something.
And there we go, okay, so you have to change your pitch. Now you get
So, let's, I found something, everyone.
Hey, everybody. He's got something he's gonna teach everybody, so.
All right. Can you guys, like, gather around here or,
Maybe some people knew this.
yes.
Who knows?
So apparently, I was told out here that your machine, when you guys set up BiPAP, you cannot set a respiratory rate. You can. So, turn it on. You're gonna set up your mode of bi-level. And then after that, you are going to go.
The other thing they mentioned is the age of this lady for bacon.
Come on, change the mode. I keep forgetting that you have to push forward.
Yeah, so there's Salt Lake, there's Salt Lake.
So once you choose by level, if you know the bottom right corner of your ventilator, the bottom where it says the mode, you push and hold that the button that's right next to it, it's gonna take you to a mode menu. That mode menu is gonna have 3 numbers: PIP target, BPM, that's breaths per minute, and then I2E ratio. In order for you to be able to move the respiratory rate higher than what it said already, you have to move your PIP target higher than that. Okay? So select that, and then you move your PIP to 25. And then push the check mark, then the breaths per minute, you can change it to 15, 16, whatever rate you want. Select it, and then you can move your I2 ratio, and that's gonna allow your patient to breathe the respiratory rate that you set, okay? So you can set a respiratory rate on your bi-level that you have, okay? Are we clear on that? How I got to it?
You should go be a Zoll rep. They never
The
taught us
Zoll rep
that.
didn't tell you that?
No.
They probably didn't know.
Yeah. Okay.
I understand it.
I need to be a rep.
Yeah, you do. You should be getting a commission right now.
Like, we were talking on the way down, like, I understand it enough to know what's going on, I don't
And then
understand to the extent
you,
that I
seems
should
like you guys have a leak
determining
compensation
whether
mode
something
here
happened,
as
right?
well. That's helpful when you put them on BiPAP, if you are capable and able to turn it off, turn it on and keep it on. Because the majority of the BiPAP machines, when you put a mask on, if you cinch it on, there's still probably like patients that have beards that are not willing to shave them or whatever. That leak compensation compensates to up to 40 liters per minute of leak. It's not very much, because, but it works. Well, 40 liters in BiPAP is really not that much, but it can compensate quite a bit. And that will help you with your ventilation process, okay? Any questions about that? Anybody not comfortable setting this up that I need to walk through? No? Did you guys get to it on your own machine?
Yes.
Okay, perfect. So, found something good here. Like I was telling, what did I tell everybody here? Oh, I told them about that's how we found it out, because they told me, we cannot set up a respiratory. I'm like, oh shit. We can. So please set it up, okay? Respiratory rates are movable in your ventilator, move them if you need to. I know that CPAP you can, because CPAP technically is not a mode that is supposed to have a backup respiratory rate. But BiPAP should always have it, okay? All right, any questions about that? Everybody feels comfortable then, sitting at CPAP or BiPAP mode? Everybody? Perfect. Perfect. All right. Do we need a break? Do we need a little break, or are we good?
That's why I took a stance.
And how much time do we
We
have?
take 5
About
minutes.
45
You
minutes,
got
an
any
hour,
time if you
whatever.
want.
Oh. 2 minutes.
They'll still they'll start getting angry at 12.
At 12? Well, me too.
He was.
Words. Look at all those eyes and E's. Hellos, though.
He was writing stuff down outside. Well, I was.
We got
I got that. X, Y, Z does not equal A, B, C.
Also, what would I ask?
Exactly. Show me, maybe I can write it down. I'll do the 50-50. I mean, we had one last night.
Oh, yeah.
I gotta ask for it. I don't really want to tell it if you want to. How much time do you have in or it's a one player. You add another 2 breaths, you're cutting it down. So every time you move it, automatically.
So that's where automatically. Yeah, for sure. Yeah, until 11 p.m.
So what you're using from your I rate, from your E ratio,
You know that she had an interview Monday morning. So don't expect her one time. I mean, we'll definitely hold it over her head on her final evaluation, that she was late. That she had to leave her. Yeah. But you were late on the first one.
Yeah.
Yeah, like the 1.5 is like, think of like.
It's just about a connector and then you have to bring it.
It's one breath.
Are you ready, sir? Yeah. All right. He's ready. So, something that was brought up that I think is important for everyone to understand. So there was a question about I to E ratio, okay? So anytime that you move you remember I told you that respiratory rate and I to E ratio are directly related to each other. You move one, the other one is gonna move, right? So how does that work? So I to E ratio has to do with time. How much time it spends on inspiration and how much time it spends on exhalation on every minute. So 60 seconds, right? So if you have a patient with a respiratory rate of 10, how much time is it gonna spend on inspiratory time and how much time is it gonna spend on expiratory time? I want you to understand this. So if you have 10 breaths a minute and every minute has 60 seconds, how much time is it gonna spend on every breath? 6 seconds, right? But out of those 6 seconds, 1 second is gonna be for inspiration and the other 5 seconds are gonna be for exhalation. That's how you get an I to E ratio of 1 to 5. Are we clear on that? Yeah. All right. Now, I was telling everybody that because respiratory rate is directly related to inspiratory to IE ratio, so if you move that rate to 10 to 12, you're cutting this number, right? Because you're utilizing more time out of the inspiratory time or more time out of the 60 seconds in order to fit this 2 extra breaths. Now, the question was, I'm not understanding why if I have a respiratory rate of 10 or 12 and this number automatically moves, how can I just manipulate this number as well? You can, because when you manipulate this number, let me start over. When you manipulate the respiratory rate and the I to E ratio moves automatically, the ventilator kind of just calculates on an even way how to separate the inspiratory time to the expiratory time, regardless of how much time it gives it. It gives it 0.8 of a second to 3.5 seconds or whatever. But you can also manipulate it by, let's keep it on this simple end. You have 10 breaths at a 1 to 5. If you don't like the 1 to 5, what you can do is tell the ventilator, what I want you to do instead of 1 second, I want you to put it at 0.8 of a second, and then this exhalation time is gonna be 5.2 seconds. Does that make sense? That's how you can manipulate also this number without this number being moved. What I'm trying, yes?
So a question with that, I wasn't sure if we can switch that one, first your inspiratory rate
On this machine?
And last time I was proved wrong as well, just the respiratory rate, so I'm not sure.
We don't know this machine.
So I didn't figure that out, it was only changing.
Yeah, so the only thing, the one thing that I noticed here is that you can move the expiratory time. And let me have it restart, because it might be different with invasive versus non-invasive. All right, so on your specific machine, it looks like you can only move on BiPAP, you can only move your expiratory time, but not your inspiratory time, okay? You can manipulate how much exhalation they have, make it shorter, make it longer. However, when you do that, it manipulates the inspiratory time. How do I explain to you? It always has to divide the 60 seconds evenly. 60 seconds, it has to be 60 seconds. You cannot give them 62 seconds, it has to be 60. So regardless of this number showing a 1 here, what it's allowing you to do is not move this number. If you, oh, sorry, that's not mine. If you move this 5 and make it 5.4, it cannot leave this 1 at 1. It's impossible. And the reason for that is because this 0.4 that you just added has to take it from somewhere in order to create the 6-second period on every single breath. So if you add here 5.4, you might not see it on the machine. It's not gonna show you the number, but right here it would be 0.6. Does that make sense? Am I being clear on that? So in order for you to move the I time to whatever you want, you have to manipulate the E time on that ventilator, okay? Because when you move this one is gonna automatically move, okay? And you can see it on the same way on the ventilator when you put a respiratory rate, the higher you go to the higher you move the rate, it shortens down that I time so that it can deliver that many breaths that you're telling it to do. And then you can go to the back menu and extend that E time in order to move that specific time that you're giving for every breath and manipulate it to however you want. Did I answer your question?
Yes.
Okay, awesome. Are we clear? Do we understand? Do I have to clarify any other stuff? No? Okay. All right. Now, modes. So, even in the respiratory community, there is a fight as to what mode is better than is volume better than pressure? Is pressure better than volume? Which one do I put on people? Okay, so this is my theory, this is my doctrine. Please don't go tell everybody old numbers because it's like this. This is my theory, okay? So, when I started my career as a respiratory therapist, I started working at Auckland Regional. Auckland Regional was a hospital that utilized all of their ventilatory management utilizing volume control. Then I moved and transitioned over to the university, and the university moved had their ventilatory strategy to pressure control. But then COVID happened, and during COVID, the university moved back to volume control. Okay, so my brain was all confused. What do I do? So this is what I have found out. When you have patients that are hard to ventilate, meaning doesn't matter how much pressure you put in them and they're not getting the tidal volume, put them on volume control. When you are having patients that are easy to ventilate or that they have injury in their lungs or they have a pulmonary disease, put them on pressure control. Unless your tidal volume is not appropriate, and then move them on volume control, but watch your peak inspiratory pressures. Okay? Did that go over your head, or are we clear on that? So, you have a patient that is 650 pounds, and the patient is unable to breathe, COPD exacerbation, have been breathing fast for such a long time. You go intubate them, you put the tube in the right place, you hook them up to your ventilator, you put them on pressure control. Tell me what pressure you would put them on. What weight did I tell you? 650. I would start at a pressure of 25. 25 over 10. Anybody wants to explain why I start with this number?
They have all that mass pushing.
Okay, so what is gonna fight with the mass first? Both of them, right? The PEEP is going to help the lungs overcome all of that pressure of the fat that is on top of them. Okay, well, that PEEP is just gonna help with the oxygen, but I also need to move that mass to give them ventilatory movement of the air, right? So that 25, that's where it's gonna be. What's your peak pressure going to be at? Do you guys know how to calculate a peak pressure without having the vent in front of you? Peak pressure is the result of the addition of this two. So your peak pressure is 35, or should be 35. Okay? This one plus this one. Okay? Because that's what you know as total pressure, right? Is that gonna be changing every once in a while? Yeah, because this number is just calculating for what you're setting, but it's not calculating for any restriction or anything that the actual body has. So the ventilator is gonna give you this number, but then when you connect it to the patient, all of that fat and all of that is gonna add even more, and so it probably might be 40 or 45. Is this a scary number, like for a peak pressure? At AirMed, our limit of peak pressures are 32. So I'm going higher than what they're telling me by setting somebody there. Why am I doing that?
Because of their size.
Because it's a guideline. Because I don't give a crap if you tell me that 32 is my limit. If my patient, I put him at 32 and I have tidal volumes of 100, then I would look like an idiot if I drop a patient like that, right? So I want you to understand that, yeah, there's numbers that we tell you shouldn't go higher than that, but it's a guideline. If you have a patient that's 650 pounds, I don't care how much you do, you're gonna go higher than that. If you have a patient that has lungs that are mush in there, like pulmonary fibrosis, or they have tuberculosis, or those kind of things, you are gonna go higher than that. So I cannot come here and teach you all of the pathophysiology of every single disease that is out there. That's your job to be able to study that and try to figure out what diseases are gonna make lungs harder to ventilate and what diseases are not. So please review on that. In order for you to understand ventilatory process in a better way, you should be able to know what diseases are easy to ventilate and what diseases are not, okay? But once you understand that, then you're gonna be able to understand, okay, yes, they tell me that I need to keep a peak pressure below that, but I have this disease, so unfortunately I can't. Unless you want me to look like an idiot, then I will do it, right? So this patient with that setting, what respiratory rate would you put him at? So think about it. If you go out there and you start seeing at a patient that is a normal person, that is not, they're not calling you for anything, you're sitting, drinking a soda, wherever, and you see a 650-pound man sitting on a chair, how fast are they breathing?
20 plus.
They're not breathing 12 to 20.
No.
They're not. So 25. So why in the hell would you put someone that is already having a disease process at a rate of 18? You wouldn't, right? So this is something that unfortunately, and I please, if it has been you before and I've told you what, please, I'm sorry, but this is what I want everybody to understand. Ventilation and oxygenation and the setting of patients on invasive ventilation, your baseline to put those patients is everything that you see when a person is normal. That should be your baseline. What do you breathe at when you are sitting there and resting? Your respiratory rate would be, I don't know, 14, right? So why would I put you at less than that? There's no reason. A patient that is 650 pounds, then what's the rate that I would put him on to start with?
20, 24.
24, right? Good job. Now, You look at your ventilator and your ventilator is spewing this out. Your rate is 24, your tidal volume is 150, your peak pressure is 45. Fix it. Is a tidal volume of 150 appropriate for a patient, an adult man? No. So, do you guys have guidelines or policies about what tidal volume or cc's per kilo you use for patients? Height.
We've got a chart in there.
Okay, so you guys use the ideal body weight stuff? Okay.
We've got pretty much the same chart as.
Oh, perfect. All right, so normally we put patients at 6 cc's per kilo. So let's imagine, right here. So I have a patient that is 5'4". 5'4" male. What's your cc's per kilo that you should have him at?
355.
355. So over there. I don't know what your name is, I'm sorry, but you. Okay, so you have a tidal volume of 150, I want it at 355. Tell me what to do. So remember, that's why we have this. So is your respiratory rate gonna help your tidal volume? No. Technically, yes, right? It will, because it's ventilation. But is it gonna actually move the tidal volume? No. What moves tidal volume? You remember the formula? Tidal volume. So respiratory rate is not gonna fix it, minute volume is gonna fix it. So on these two numbers, which one is gonna move the volume? The top number. So if my number is low, what do I do? Okay. Is my number a little change or a big change? Big change. So am I gonna move two points? No. I'm going to 30, right? 30 over 10. So now my peak pressures are what? 40? Technically my ventilator is gonna tell me 50. Is that good? No. What do you need to do to fix it? At this point, if you already moved it once and your tidal volume now is 205, is that appropriate? At this point, why would you keep playing with the same mode? If what you did, you moved by 5 and your tidal volume is not appropriate, why would you keep doing that?
Switch to volume mode.
To push the volume up, but you already did by 5. And so you're at 30 and your peak pressure is 50. Do you think that would help? It probably will, but in order for you to get a tidal volume of 355, you'd have to put this patient at 40 over 10. That's huge. That's a big, huge pressure. Does it require it? Probably yes, but this patient is hard to ventilate. What did I tell you about modes? If you have someone that is hard to ventilate, what do? Put him on volume. Stop wasting your time trying to figure out what pressure you're gonna use. Put him on pressure control, move it once, give it a 5-minute time to see if the tidal volume is appropriate. If it doesn't work in 5 minutes, you need to do something different. One thing that I don't want you to do is be fidgeting with the ventilator every 2 seconds. So, historically, ventilators have a time of 1 to 2 minutes for the ventilator to be able to figure out the changes that you're making and give you a good responsive result within that time. So if you make a change of a ventilator and you change it every 2 minutes, are you giving it the time to give you a positive response? No. So please slap your paramedics partner's hand if they're like 25, oh it's not working, 30, it's not working, 35, it's not working, within that 2 minutes say, quit it. 25, leave it alone, give it 5 minutes, if it's not working, then do something different, right? Something that is appropriate. So this patient, let's say you have them on that, in order for them to ventilate, so what would you transition them to? Do you have to change if everything else is normal, other than the tidal volume, do you have to move anything else to transition them to volume control? No. So you would put him on volume control, same rate, 24, same PEEP. Oh dear. PEEP of 10. What tidal volume?
350.
Where did you get that number? Right. So don't make it more difficult than it is. Whatever tidal volume they're telling you to put him on, if it's not ventilating on pressure control, there's no guessing. Just put him on that volume, right? So if your volume is 305, so 305 and PEEP of 10. I don't know that ventilators can do half numbers, so it's usually 310. Right? So once you have that, there's a big problem that a lot of people, including respiratory therapists, doctors, anesthesiologists, everybody has an issue with. You said those things, but then your problem is this. You have a respiratory rate of 24 on the screen. You have a tidal volume of 250. You have a PEEP of 12. But then you have a big fat, where's the other one? A big fat light on top of the screen that's telling you something is wrong. What's wrong?
Pressure.
Are you getting the tidal volume that you want? Why not? You said it to give it a volume of 310. Why are you not getting it? And this thing is alarming. And that's the problem. People forget that when you set up a patient on a ventilator, it's your responsibility to tell the ventilator when to limit things, right? So if you set up a ventilator on pressure control, volume control, you automatically have to go to your alarms and widen your alarms to give the ventilator the opportunity to do what it's supposed to do, okay? Time and time and time again, people keep moving from pressure control to volume control, but then they don't move alarms. And so this ventilator would be alarming because you have a peak pressure of, let's say, 35, and your peak pressure alarm is 32. Do you guys know what an alarm is on a ventilator? What is the purpose of the alarm?
Get your attention.
It's more than get your attention. It's actually a hard limit. So what you're telling the ventilator is that those alarms that you have there, the ventilator is not going to allow the patient to go any higher than that. So why, if you already had a patient that was on pressure control at 25/10 and a peak pressure of 35, if you put him, and your tidal volume was 150, do you think it's theoretical to transition him to a volume that has a volume higher than what you had and keep the alarm at the same? It's not. Does that make sense? So that's another thing that a lot of people forget. Please remember, anytime that you change a mode from one to the other, think of what's happening on the mode before. I know that I'm telling you a lot of things that you need to think about. That's why paramedics are awesome. You guys think about a lot of stuff. You gotta take care of a lot of stuff. You guys are good at managing several things. So it just takes a little bit of time, a little bit of focus, right? So if you're focusing on setting up the ventilator, give it a good 5 minutes to set. Okay, I have this patient on pressure control. These are my alarms. This is what's happening. My tidal volume is not appropriate. Where was my alarm? I'm gonna transition them to volume control. Where was my alarm before? I need to widen up a little bit. Make sure that all of those things are good. Before you touch anything of changing a patient that you transition from one mode to another, the first thing that you need to change is alarms, okay? Because those alarms are limiting what you are telling the patient to do or the ventilator to do. And a lot of people forget that. So, am I clear about what I'm trying to say? One mode, transition to the other, set them on whatever you think is appropriate, and then move your alarms. And then after you've moved your alarms, if that's still not giving you what you need, then make a change. What changes do you usually make? Or I should say, how many changes do you usually make every time you touch a ventilator? What I want you to do is limit it to 2. Don't change more than 2 things at a time. Why is that?
You don't know what worked.
Exactly. So if you make so many changes, you're not gonna know what actually is what made the difference. If you make 2 at a time, you should be able to at least figure out, okay, this two didn't work, let's do the next two. Or if this two did work, which one was it? And it's easier to figure out versus, oh, I'm gonna change the respiratory rate and the tidal volume and the PEEP and the eye time and all of that. That's for the ICU to take care of. That's not for you to figure it out, right? Give it time. Like I said, one of the problems that I have had a lot of times, and AirMed is awesome, I love AirMed, they're the best, we have the best people there, but damn, some of us paramedics, I'm just kidding, not him. Some
Like I
of
said,
us,
share your story.
no, it's not him. No, but some of the paramedics that we have that problem. And if I see those problems there, I guarantee they're out here in the field, right? People change things over and over and over and over without giving it time to be able to work. Giving it a good 5 minutes, changing less than one or two things at a time, okay? So please do that. Sorry, I just have kind of like a little outline here that I'm working on. Any questions about the alarms? No? So you have four different alarms, right? So tidal volume is one, minute ventilation should be another one, peak pressure should be another one, respiratory rate should be another one. Okay? Move those alarms. What's appropriate for alarms to be moved at? I would say 5 to 10 above. Always 5 to 10 above. On a respiratory rate, 5 to 10 above. On a tidal volume, 5 to 10, just add 100 to that. So if your tidal volume is 450, put it 5 to 10 is 500 above. So a maximum of 1,000 should be your peak pressure, your tidal volume higher, a minimum of 250. If that's too wide for you, at least give them 200 to 300 cc's of room to move, right? Peak pressures, 5 above, okay? And then, what was the other one? Minute ventilation, same thing. 5 to 10 between top and bottom. Does that make sense? And then one of the things that I was asked by Jason was this. Do you recommend if people go to a facility and pick up a patient and have them put the same settings that they have at the facility?
That's where we start, and then we always end up adjusting stuff because it's a different machine.
Okay, all right. So that's two different scenarios. What I want you to do, if you go to the facility and whatever they're doing is working, why would you change it?
We often find, in my experience, that we put them on our machine at the same settings, but our machine seems to affect the patient different, and for comfortability levels, they're not as comfortable on our machine.
Right.
So we have to make minor adjustments.
Okay, so one of the things in order to answer your question is the same problem that we used to have with the ventilator that we have at AirMed, the smaller one that we used to have. And it's the same principle as this. So ventilators at the hospital are turbine-driven ventilators, okay? So they have kind of like a turbine, like an airplane, that provides the tidal volume for those ventilators. And transport ventilators, the smaller ones, are pneumatic ventilators, okay? Which one do you think is more powerful? The turbine one, the hospital ventilators. So rule of thumb, you go pick up a patient with this ventilator that they have at an ICU over there, always go 2 higher, okay? So if they have them on a peak pressure or a PIP of 12, PEEP of 10, PEEP doesn't change. PEEP is PEEP, regardless of what ventilator you have. But pressure or tidal volume, that actually differ because of the way it's delivered by the ventilator. So if you have them on 12 over 10, put them at 14 over 10. That should give you the little bit of comfort of the tidal volume difference that ventilator is going to create. And then for tidal volume, if you have them at 400, always have 50 cc's. Okay? So the other thing, your circuits are different. So for every 66 inches of tubing, there is how much dead space? Do you guys know that? 100 cc's. For every single 6 inches of tubing, there's 100 cc's of dead space. So if you're tubing, it's different than theirs. However, the length it is, you're taking away 100 cc's of dead space. And that's one of the reasons of why I'm telling you to add that pressure because the majority of the ventilators at the hospital, their ventilators compensate for the circuit versus these ventilators that we have right here, like the Zoll or the Revell or those ventilators, they compensate to a certain degree, but they're not as exact as those. So please just add that. And anything that,
One of the things that might be useful for us too, that I've done, is if you have that patient that we're trying to transfer over, instead of just taking a swag at it, right? Ask for a recent blood gas. If things are improving or have a good baseline, then start attaching our stuff onto their ventilator. Because we really wanna mirror what they're doing, especially if they have good ventilation strategies and everything is on the up and up, right? So you can actually hook up our end tidal on their ventilator and, hook up our monitor, see what their sats are, and, everything that we can grab. So we get a baseline with those numbers on their ventilator that's been giving them good blood gas values, and then we switch over to ours. If we notice a change on our end tidal, then we can adjust our ventilator to get back to that baseline end tidal. That makes sense? So just take a second, throw on our equipment, and then that'll give us a little better idea, other than kind of swagging because we don't know, add a little bit here, add a little bit there, right? Then we can maintain what strategies that they've been doing.
yeah, thank you. And he just jumped into what I was gonna head into, right?
Sorry.
No, you're okay, you're totally fine. You have tools, use your tools, right? The hospital is giving you the numbers. If the numbers are correct, if what they're doing is working with what he said, a blood gas, you guys know what normal blood gases are, right? If you don't, then you need to study. Please know
I'll have
those
an
numbers.
H and an L on the printout they give you.
What was that?
I said it'll show H or L on the printout they give you. You can figure it out from there.
Okay, so it's important for you to know respiratory acidosis, respiratory alkalosis, metabolic alkalosis, metabolic acidosis, which one is compensated, which one is not compensated, right? Please review all of those. If you want me to go through them, I can. If you don't want me to, that's fine too. I was asked to do ventilator stuff, so if you want me to, I can. That's fine. But if those numbers are appropriate and correct, what they're doing is appropriate and correct. So utilize those tools that they have there, if you have them, to do the same. Hook them up to your machine, to your entitled, you put them to your ventilator. If your entitled starts creeping down, there's a problem, right? And then just change it appropriately. Just because I'm giving you those hard numbers of 2 above or whatever, that doesn't mean that's just like, that's what all you should do. What he said is exactly what I was gonna go into. Use your tools that you have so that you can give them the best care that you can with what you have. Okay? What other thing? Went through alarms. Okay. Then just disease processes and what you set them up on. COPD patient. So, COPD patients, what's their problem?
Ventilation issue.
Why? Somebody else. I mean, advanced EMTs should know this too.
Obstruction in the lungs.
There's an obstruction in the lungs, right? Why is there an obstruction?
Restriction on the airways.
So, obstruction or restriction? Because there's two, restrictive disease and obstructive disease, right? So, chronic obstructive pulmonary disease, it's typically due to an inflammatory process of the airways due to something that they have done. Smoking, emphysema, any of those diseases that, because of an external factor, creates inflammation of the airway, that's an obstructive disease. A restrictive disease is something that they don't have control over, that has made it so that their lungs cannot expand. So, give me an example of a restrictive disease. That's pulmonary related. Huh?
Cystic fibrosis?
Cystic fibrosis, perfect. Another one? What are the CHF? Sure. What do you call people that are twisted like this? They're like that all the time. They have
Scoliosis.
kyphosis, scoliosis, kyphoscoliosis, all of those are restricted diseases. The reason for that, you can see that, right? They're being sideways like this crunches this side of the chest and it doesn't allow the lung to expand completely. You treat those differently, right? So obstructive patients, what I want you to be mindful of is their lungs are damaged already, so be mindful of their peak pressure. Give them lower tidal volumes. So our policy at the university is for COPD patients, we start at 4 cc's per kilo every time. And then if they're not ventilating appropriately, we move to 5 cc's. If they're not moving air appropriately, we move to 6. And after 6, we stop at 6 and then we start moving respiratory rate. Okay? So 4, 5, 6, that doesn't work, respiratory rate. Something important for COPD patients, what their CO2. They've lived with a high CO2 for a long extended period of time. Their body has compensated to that and that's their normal. What's their normal CO2 on a COPD patient? Anybody has any idea?
50s.
Yes. So 50 to 55 is what they live on normally. So if you have a COPD patient that is at a CO2 of 50 to 55, they have them in the ventilator up at the hospital and their entitled CO2 is 50 to 55, would you put them on a rate that drops their CO2 lower? Please don't, okay? So maintain that. So that's what I want you to remember. COPD patients, anytime that you put them on that, what I want you to do is put them on a lower respiratory rate. So start at 18 to 24, somewhere in there, because they are breathing faster to compensate for that high CO2, that's what their normal is. Then put them on a small tidal volume, 4 cc's per kilo, and then maintain their peaks at 8 to 10. If you hyperexpand those lungs, you're gonna damage them. If you need to, do it. If you don't, don't. And then the FiO2, I understand that they say that yes, 100% drops the respiratory drive or whatever. Do what they need. Don't worry about that. Do what they need, okay? Any questions about that COPD patient? Asthmatics. What about asthmatics? How do you guys manage asthmatics here? Oh, I forgot about something. Don't ever think that a ventilator is a magic answer. You cannot fix a COPD patient just with a ventilator. You also have other tools. So medications, right? What medications are you gonna give them? A COPD exacerbation. They can't breathe. So what do you do? Okay, albuterol. Do you guys carry Atrovent here? Do you want it?
Atrovent.
Okay, so let me recommend to you. Let me recommend to you a COPD patient. Don't start with albuterol straight. Just go straight to Atrovent. Atrovent has been proven to attach to chemoreceptors that are specific to COPD, and they actually do bronchodilation faster than albuterol does. So do Atrovent, and it also doesn't increase the heart rate higher, it's not as responsive as albuterol is, and COPD patients have like a tendency to have a higher response to albuterol than on their heart rate increase and utilizing Atrovent. So use Duonev if you can, and I would double the dosage if that's something that you guys can do. So what dosage of Atrovent do you guys carry here? 0.5. The 0.5, so give them 1. And then albuterol, you guys, do you know how much you carry here?
2.5.
Just 1 vial, is that what you carry? You carry a lot. Okay. So what I would do is I would give them, with COPD patients, I would give them Duonev after Duonev after Duonev. Just keep giving them Duonev. It's not gonna hurt them. On asthmatics, give them a Duonev first and then albuterol after. Okay? That's our practice at the university, and we always double the dosage. The reason for that is the amount of medication that is, especially if you're gonna deliver it to them via mouthpiece, the amount of medication that actually gets deep into the airways is not very much because of the fastness of the breathing. So double the dosage, and then you should be able to cut out that exacerbation faster. With a ventilator, how do you guys deliver nebulizers with a vented patient? Do you guys do that? No. What about BiPAP?
We have an inline.
Can you guys do inline with BiPAP? If a patient, so one thing that I have learned with AirMed, if you ever question that a COPD patient needs BiPAP, if it ever comes to your mind, just put it on. Okay? Put it on, but then don't put it on with nothing else. Put it on with a breathing treatment. together with it. Because the BiPAP, so think about it, what did I say COPD was? Obstruction because of what? Because of an inflammatory process, right? So fix the inflammation and fix the bronchoconstriction with stenting of the airways with a ventilator, with a non-invasive mode, right? So the bronchoconstriction is fixed by albuterol, Atrovent, all of those medications. How do you fix the inflammation? Can you fix it right away? No, but you can start. Do you guys carry Solumedrol? No. No? Dexamethasone? Nothing like that? Okay, then that's out of you. That's none of your thing. But so that's what we do at the hospital. If I can fix it, I know that dexamethasone and all of those things take hours and hours, but why delay it, right? Because it's an inflammatory process that creates bronchoconstriction and it also mucus. Another thing that I don't see here that I would recommend, do you guys carry a heat moisture exchanger? Like a HMEF filter? You probably should, especially for COPD patients. Patients that are COPDers, when they start, when their airways start to become inflamed and bronchoconstricted because of the inflammatory process, one of the things that happens is that when the airways are touching each other, there's like finger-like projections in every single surface of the airway on the inside, and when they touch each other, that's what produces secretion. Asthmatics, that's why when they can't breathe, they start producing a lot of mucus because they're so inflamed and their airways are touching each other and they start trying to cough all of that mucus. So heating and humidifying the air allows to relax those airways a little bit better. That's, in fact, we are transitioning the primary mode of treatment for COPD patients from non-invasive BiPAP to high-flow nasal cannula for that reason. So, any questions about that? I would recommend, if you guys can, add a filter to that adds a little bit of humidity. I know your transports are not very long, but those things in 10 minutes start producing humidity for those patients, and it's helpful to them, if you can. If you're gonna do that and you're gonna do breathing treatments, just remember to put the breathing treatment after the filter, because if you don't do it, the medication just gets filtered in there and they get nothing. Any questions about ventilation processes for COPD patients? Like, that's how I set them up to start with. And then eye times, I usually keep their eye times between 0.6 and 0.8. And then the rise time, which I know that you guys cannot control here, but just the rise time has to do with how fast the breath is delivered as well, together with the eye time. Keep it as low as you can. Lower rise time, which is faster breath taking, that's what they like. So I know that you guys can't control that, but with your inspiratory time and your expiratory time, what you need to do is just extend your expiratory time so that you can exhale, but don't go any higher than 0.6 or 6. On your IE ratio, don't go any more than 1 to 6. It's too much, because then they start trapping air in their lungs. Sorry, I'm going with information that like too fast. I'm sorry. If you guys have questions, please blurt them out.
I think we're ready for the test. You guys ready?
Yeah. Asthmatics, the same. I would put asthmatics also at a. Have you guys ever intubated an asthmatic patient? Yeah, so if you have to transport an asthmatic patient from one facility to another and they're intubated, what I would like you to do, if you can and they will allow you, if the patient is sedated enough but producing their own respiratory rate or respiratory effort, I would put them on CPAP so that they can produce their own respiratory rate. As long as they produce proper tidal volumes, that's the best you can do. They do not like to be ventilated. If you can do that, do that. If you cannot, if for any reason they're completely sedated and paralyzed or whatever, then just ventilate them, utilizing PEEP to your benefit. Asthma is also an inflammatory process. Give them a little bit more PEEP and give them small tidal volumes of 4 to 6 cc per kilo. Those patients are the ones that you can blow pneumos faster than anybody else because of the inflammation of their lungs. So be aware of that, okay? I think I've covered everything that I've been asked to cover. Oh, high flow isotonic. You guys want me to talk about high flow real quick? Are you guys good with that? Are you guys very familiar with high flow?
Yep. Oh, yeah.
Yeah? Do you guys use it a lot?
A lot of transfers.
Huh?
A lot of transfers we do.
Okay,
The people that are in the spot to use high flow are pretty savvy with it.
perfect. Okay, so just use it. So the studies have shown that high flow nasal cannula has a better delivery system than BiPAP does. It doesn't have the pressure that BiPAP does. So if you have a patient that is struggling with like CHF exacerbation, big huge shortness of breath, but they're like really high on the end of their disease, like a respiratory rate of 35, 40s, high flow is not going to do anything. But if they're like in the middle of the process where they can't breathe, but they're still breathing maybe 25, 26, high flow is really good for them. Maximize the flow. So are you guys, I'm just gonna run through this really quickly. The flow of high flow, it's for worker breathing. And obviously the FiO2 is for oxygenation, right? So if your patient has a hard time breathing, you have to increase the flow. If your patient is not sating well, you have to increase the FiO2. When you guys transfer patients, do they just have them at a regular flow and you guys just put the same flow on? Is that what you guys do normally? Okay, and what flows do you normally see on those patients?
Pediatrics are like 8 liters.
8?
I mean,
That's
the
the
highest
last
I've,
one that I've seen.
I think the highest I've seen was 50 liters per minute
50 on an adult?
on adult, yeah.
Okay.
Seems like 30 to 40 is pretty common, right?
So 30 to 40 is pretty common?
Ish.
When you transport those patients, do they still look like they're struggling to breathe? No? Okay.
Most of them do pretty well with it.
Okay, perfect. So this is just for your guys' information. If, for example, you're transporting a patient and all of a sudden they start feeling short of breath, increase the flow. The flow is going to increase their inspiratory demands and it's going to help them with their breathing. And then oxygenation is just the FiO2, move it up or down. I have no idea what device you use, but anyways. Any questions? Anything that you want me to answer? No, I know that it was a lot of information. I know that it was boring to some. I'm sorry.
It was great information.
Thank you.
Any strategies that I can share with you that I didn't talk about? Anything that we didn't talk about, you tell me.
Me too.
You guys good?
Thank you.
All right. If you have any questions of anything, I'm willing to answer whatever. You can reach out to Jeremy or you can reach out to Jason Cook. Sorry, to be cheap whatever or whatever. Just reach out to them. They can pass it on to me and I can send information. If you want me to send you the studies that I mentioned, information that I mentioned at all, just hit him up and I'll send that information to you. And thank you. Thanks for letting me know.
Thank you.
While we're out here.
Thanks, Ray. Appreciate it.
Yeah, you're welcome. Hopefully that was